Tonight's event is supported by the Scottish Government, and PET are extremely grateful to them for their support. So the discussion this evening is how old is too old to be a parent? And during my time as director at PET over a decade, this topic has come up, but we've never actually held an event on it. It's always been sort of tangential to other discussions. And I think that's because it's well documented that there are risks to women of pregnancy and childbirth and at advanced age. And depressingly, I now fall into this category. And I don't know why I'm saying now, I've been in the advanced age category for quite some time. There are also risks to the baby, which I'm sure we'll hear about too. And interesting, when I've been looking into this, doing some research for this event, data from the ONS, the Office of National Statistics, showed that women aged 45 years and over were in the age group most likely to have a multiple birth in 2017, where just over 77 women out of every 1,000 giving birth in this age group had a multiple birth. But there is some good news about this, because it is actually the lowest multiple maternity rate since 2006. So perhaps that's a really positive indication of the success of the single embryo transfer policy. Now, conversations on this topic often seem to gloss over the man's contribution to this enterprise, but men, fear not, you will not be overlooked this evening. And I wanted to quickly share with you an email that we had from Brian Woodward giving a scenario after the last event. And that is, he said, I have some experience of trying to help older men with younger partners achieve parenthood. For men in their 70s and 80s, they may be unable to provide a semen sample. I recall one such chap showed me all his prescription tablets, many of which were for cardiac problems, prior to him entering the sample production room. I showed him the emergency cord in the room, but I was quite concerned when an hour later he didn't reappear. So I knocked on the door to check he was okay. He was fine, but no sample was produced. Now, for gentlemen like this, non-toxic condoms could be used for home production. However, if that fails, surgical sperm retrieval may be the next option. But Brian says, I ponder about the ethics of this. But if informed consent is provided, then it's a patient choice if they can provide a private clinic to agree to treat them. So it might be something that comes into the discussion later. And while we might all agree that the state should stay out of our private lives and our bedrooms when it comes to natural conception, do we think it should have more of a say when people need help to conceive? Should there be upper age limits on all fertility treatment and gamete preservation? How much of a problem is your chronological age? Are health issues actually more significant? And then what about the costs, the prenatal, the maternity costs and the postnatal costs of treating older women? These are picked up in the UK by the NHS. Is this acceptable? And if not, what can be done about it? So luckily, I'm not going to be answering any of these questions, but we'll be hearing from 4 marvellous experts. Dr. Sarah Stock, Dr. Sarah Martins de Silva, Dr. Anna Smajdor, and Professor Glenn Cohen. They're each going to give presentations, and when they've all finished, we'll open up for Q&A. So it gives me great pleasure now to introduce this evening's first speaker, Dr. Sarah Stock. And Sarah is a consultant obstetrician and subspecialist in maternal and fetal medicine at the Royal Infirmary of Edinburgh. She's also a senior clinical lecturer in maternal and fetal health at the University of Edinburgh's Centre for Reproductive Health.
Well, I feel particularly well qualified to talk on this subject, partly because I work as a consultant obstetrician and researcher in this area, but partly because I come from a long line of older mothers. My grandmother, my mother, and myself all had our children at what could be considered above average age. And I spent many of those 9 months pondering before the birth of my daughter exactly what could go wrong. The average age of pregnancy has changed dramatically in the previous decades. And you can see on this slide that in 1976, only 20% of pregnancies were born to mothers 30 years or older. Now more than 50% of births are to mothers 30 years or older. So the demographics have changed. We talk about complications, and we can think about them broadly as maternal complications or complications for the baby. And there are three areas when we're talking about the mother. We talk about the risks of general health-related conditions that can affect pregnancy, things like raised blood pressure or diabetes. We talk about specific pregnancy complications. Sarah's already mentioned twin pregnancy, complications like preeclampsia. And then we can think about birth complications, problems in labor requiring operative delivery, cesarean birth, or bleeding problems, infections around the time of birth. But these complications vary in severity. It's difficult to know whether they're clinically important. And so this paper here, which is from the United States, tried to think about severe maternal morbidity. That's which really counts. Conditions that are potentially life-threatening, potentially life-changing, things like intensive care unit admission, and things like admission to intensive care, sorry, I have a child just come in. So when we think about this, the severe, what really counts maternal mortality and morbidity, if we think about age 20 to 24 years, 15 per 1,000 pregnancies are affected by severe maternal morbidity. And actually this rate doesn't really change over the next decade. It's only at about age 35 years where the reported rate increases to 17 per 1,000. At age 40 to 44 years, there's another excess 7 pregnancies affected by severe conditions. But at age 45 years or more, this rate increases to 35 per 1,000 pregnancies. And so more than double that rate that you see at 20 to 24 years. What about risks to the baby? Well, it's well recognized chromosomal anomalies are more common the older the mother is. But unfortunately, there are also risks of baby loss with miscarriage and stillbirth. And I think this paper, recent paper from the BMJ demonstrates this quite strikingly. You can see that overall, the miscarriage rate over all pregnancies runs about 12%. It's lowest in the age bracket 29 to 30. But steeply rises after age 35, such that at age 40, about 1 in 4 pregnancies miscarry. At age 45 or more than half of recognized pregnancies result in a miscarriage. But what I've done so far is describe risks associated with age, but we can't be very sure whether these are associated with age itself or of things that go along with age, because older mothers are a diverse group. You will have women who've had previous pregnancies and potentially previous pregnancy complications, and these may be recurrent, things like recurrent cesarean sections. You'll have women who've chosen to delay their pregnancy but are very healthy and financially secure, and we'll have women who've had involuntary delay due to their own health or fertility issues. And then indeed you'll have pregnancy and birth managed differently purely because women are older, where clinicians or women themselves may choose operative birth because of the associated or perceived risks of pregnancy at older ages. So we need to take these into account when we're looking at the data. And this is this American study again, which has tried to do that. We only need to concentrate here on the dark orange bars. These are significant outcomes. Again, the severe maternal morbidity or mortality, or severe baby complications or mortality. And you can see that these risks can occur at any age. But right up to age 35 to 39 years, these risks are relatively low. They remain well under 5%. At age 40 to 44, our group, the risk is approaching 5%. And the risks are higher at a maternal age at 50 or more, you can see we're up to about a 10% risk there. But notice that our precision around these estimates is much less because so many fewer women have pregnancies at this age. It's very difficult to be sure of those risks, and they may overlap the preceding time limits. So what's really important, isn't it, is that we're recognizing who is really at risk, putting age in the context of other risk factors. And I'm going to finish with some Scottish data to show what happens when we put risk in context. So this is the risk of stillbirth according to maternal age. And the purple line shows the risk of stillbirth in mothers 40 years or more. And you can see, and this is also done over time. And let's just concentrate on that purple line. I'll grey out the others. And you can see that in the mid-90s, early 2000s, the risk of stillbirth, if you were 40 years or more, was more than double that if you were younger, a younger mother. But with recognition of this, and particularly recognition that the risk of stillbirth was highest around late term and 40 weeks gestation and more, and recognition that we could mitigate that risk with timed birth, increased guidelines on induction of labour, and recognition of these risk factors, the rate of stillbirth has decreased, and such that now, if you extend out this line, the rate of stillbirth after in 40-year-olds or more is virtually approaching those that are mothers of other ages. So what we need to think about is age is an important risk factor, but it is a risk factor that needs to be taken into context with other pregnancy complications. And by doing that, we will hopefully improve the outcomes for mothers and babies of all ages.
So now we're going to move on, and the next speaker is Dr. Sarah Martins de Silva. And Sarah is a senior lecturer and principal investigator in reproductive medicine at the University of Dundee. And she runs a translational research programme focused around male infertility. And she is also an honorary consultant gynaecologist and clinical lead for infertility services and the person responsible at the Nine Wells Assisted Conception Unit in Dundee.
So as Sarah says, I am a consultant gynaecologist. I work in an infertility clinic. I'm a fertility specialist, but I have a particular interest around male infertility. And although we're talking here about how old is too old to be a parent, I'm coming in really from a male perspective. Oh, now changing slide, next challenge, hang on. Oh, here we go. So I wanted just to start off by telling you, I love Formula One racing. It's a ridiculous and heady mix of driving skill and spectacular motor engineering and team tactics and decadent speed. It really is my guilty pleasure. And so it was with some interest that I read of Bernie Ecclestone, the former chief executive of Formula One, who became a father this summer at the age of 89. And I don't know whether you've got down the side of your screen little pictures of the rest of the speakers, because I'm missing his gorgeous Fabiana Flossi, his other half. But they're a very interesting couple, and she was 44 at the time of the birth. So, you know, it's an interesting story, and they obviously live and work in a very exclusive and incredibly rich environment. And, you know, so what? It's an interesting story. But actually, the issue here is 89 too old? And I think I might think it is. And I'm going to tell you why I think it might be, but kind of also interested to kind of get to the dialogue a little bit later and see what other people think. So at the age of 89, Bernie Ecclestone's life expectancy on average is 4.5 years. And one of the sad quotes that was in the press was, he said, you know, I just hope I can live as long as I can and see as much of our baby as I can. And that to me seemed quite sad, but actually there's also quite compelling data that shows that children that lose one or both parents, clearly not perhaps in such a lavish environment that this child would be brought up in, do suffer quite significantly from mental disorders and risk in their adolescence and later years. The second issue that I have with this particular scenario is the fact that there's such a huge age gap between the couple. She is 45 years younger than him. And although I couldn't find any reference to it, I do recall in my training years that when we saw couples in an antenatal clinic booking their obstetric care, that we should always kind of have a bit of an eye out for couples where there was more than a double age gap difference between the older and the younger partner. And I think that's really founded on the fact that relationships are commonly, you know, the age gap between a man and a woman or a same-sex couple even is commonly within a few years of each other. And where you have these vast age gaps, there is often an underlying inequality in the relationship, either to do with power or money or something. And so, I don't know, I'm just putting it out there, but, you know, it's an interesting concept with this couple where there is such a vast age gap. And the third scenario is the child himself that's born into this quite strange environment where he's got his dad's great grandchildren are older than him. He's got 3 older sisters, and his eldest sister is actually 20 years older than his own mum. But on the other hand, you know, we're all so wonderfully unique and interesting, and that's the whole point, I guess, about the diversity and the of life and individual choice. Is, you know, who am I really to judge this? If you want to do, as he has done, become a father at a very old age, then who am I to say yes or no to that? It's up to an individual, surely, to choose that. So as I say, I work in an infertility setting, but clearly Sarah and I actually used to work together, Sarah Stock and I used to work together in Edinburgh in our training years, and both of us looked after pregnant ladies and so on. And what we have seen over time, clearly, is this ever increasing age of both the father as well as the mother. And so over the last several decades, we've seen an increase in the average paternal age of about 4 years. So back to you, how old is too old? We don't really have any guidelines out there. What the HFEA think is that men over the age of 45 shouldn't be sperm donors. What the Scottish government think is that men over the age of 55 should not have NHS-funded fertility preservation. But to be fair, I was part of that recommendation. So I'm not just pointing the finger at somebody else. I'm quite happy to be culpable for that one too. And actually interesting, what do our patients think? So we did a completely separate study, gaining some feedback from patients. And these were men attending for diagnostic semen analysis or fertility clinic appointments in the last 6 months or so. 215 replies. The youngest guy was 22. The oldest guy was 53. So actually patients on the whole probably think that 55 is about the kind of age that isn't too old. So why is men's age important then? Well, let's think about this in terms of quality of the sperm, in terms of the likelihood of getting pregnant, but perhaps more from my perspective, outcomes of fertility treatment, and perhaps most compellingly, the health of the next generation. So we know that as a man gets older, the volume of his sperm goes down, the sperm swim less well, they look less normal down a microscope, and they increase their damage to their DNA that they carry. But the sperm count is relatively unaffected over time. What is much less clear is, although we use these values of semen analysis to predict fertility in a man, when these things change, it doesn't necessarily play out to a definite impact on fertility. Unlike women, there is no, you know, cliff edge or age that specifically things aren't so good in terms of likelihood of fathering a pregnancy. But we do know from a couple of studies that are out there, the first of which is this study by Ford et al. Looking at men from a Bristol area, 6,500 men who took longer to conceive naturally when they were over the age of 32.5 compared to a younger age group where the average age was just over 30. And similarly, in another large retrospective study across Europe with 6,500 cases in it, they found that a man with an age over 40 was a risk for a delay in conception. So TTC is time to conception if it took longer than 12 months for the couples to achieve a pregnancy. But actually, interestingly, this was only significant when the female age was also over the age of 35. And there's also a secondary thing at play here, which is that certainly as men increase in age, there's an increased risk of erectile dysfunction. And also men have less sex. So men under the age of 40, a study published in 2004, will have 6.5 episodes of intercourse roughly a month, which decreases by 1 to 2 over the next decade, and again by 1 to 2 over the next decade again. So men have less sex, they have less erectile function, as well as these other parameters that deteriorate within the semen is probably the reason that over time male fertility declines. But as I say, there's not a specific age for that. The other issue is there's less or none pretty much well-designed prospective studies looking at the impact of maternal age specifically on fertility treatment outcomes. So there are a few studies published that show, for example, a lower IUI success rate. The issue with most of these studies, though, is that because a woman's age is such an important determinant of IVF and fertility treatment outcomes, that it generally overshadows things. Because, as I say, an older man will often be paired with an older female. But overall, IVF is less likely to be successful where a man is over 40. Certainly, independent of a female's age, there's a higher miscarriage rate that's identified where a man is over 50. Similarly, when you look at couples where they are using a donor egg, so that you exclude the element of female age, there's quite a mixed picture that's reported in the literature. So there's a fairly old study data from Fratelli et al, which showed that actually with men over the age of 50, they have a lower live birth rate and a higher rate of miscarriage in these cycles. But actually more recent data doesn't agree with that. So there's really insufficient evidence to demonstrate an unfavorable effect of paternal age on fertility treatment outcomes. So lastly, then thinking about the offspring, we know that unlike women where their ovaries and their eggs are formed in fetal life and determined from a very early stage, that the male germline continually divides and produces sperm. And across the course of time, therefore, gene faults and mutations accumulate. And there's a study from Iceland that suggests that probably about 2 mutations arise per year, which means that every 16.5 years or thereabouts, you double up your rate of mutations in your sperm cells. And certainly there are specific gene disorders that have been described that are called paternal age effect congenital disorders. And these are characterized by skeletal deformities and retarded growth, cardiac disorders, problems with skin pigmentation and susceptibility to cancer. And there's a whole raft of syndromes that are described. I've got them kind of just to kind of refer to here, but there's Apert syndrome, Cruzon syndrome, Costello-Noonan syndrome, multiple endocrine neoplasia, type 2A and B, but also achondroplasia, which is dwarfism, which is probably the one that most of you will have heard of or know of. There's also, as paternal age increases, increased risk of specific congenital abnormalities, particularly cleft palate, gut abnormalities like problems with the way that the esophagus or the gullet forms, and other chromosome disorders, including Down syndrome. So there's 2 issues here. The first one is that the overall effect is small compared to female age. But the second is, although the increment in risk is small per year, over time, those risks can become quite substantial. So that if you have a certain risk of having a child with a diaphragmatic hernia at the age of 20, that will double by the time the father's age is 40 and double again once the father age is 60. So it can, over time, be quite a substantial loss, but it's not, that isn't perhaps captured in the data that's published at the moment. There's also an interesting study from Denmark, which looked at 1.6 million children, a big cohort study over a number of decades from the late 70s until the early 2000s, which demonstrated that you had a much higher risk of your child dying under the age of 5 when you had older fathers, and old here they're using it as 40 years or over 45 years. And that was primarily due to these congenital abnormalities which were fatal, as well as increased susceptible to cancer that caused these deaths. And lastly, there is most probably the strongest evidence of the age impact on psychiatric disorders in the children born. So there's another, big data studies, one out of Sweden, one out of the US, 2.5 million individuals, and they showed a hugely increased risk of bipolar disorders and psychosis, ADHD, substance misuse, and so on. And the difficulty here is clearly that if you've got an older father, they may not live to see these manifestations in their older children or young adults. And last year then was a paper, 2018 was a paper published from the US, actually looking at the effect of paternal age on maternal health. And what they very eloquently showed is actually an older dad, and again, they were using an age of 45, was likely to have a partner that had a much higher risk of gestational diabetes. The children were likely to be lower birth weight with lower APGAR scores, which is the kind of condition of a baby when he or she is first born within the first minutes of life. A 15% higher odds of a baby being born premature, and an 18% higher chance of infant seizures. So you can't really ignore this data, but it's data that still is emerging, and there's still more to do. In summary, however, male age does affect sperm quality and sperm quantity. It does affect fertility and sperm function, but the effect of male age is uncertain on reproduction overall. But it does affect the health of the offspring. The difficulty is that we don't really have a defined age for old in men. And we certainly need more studies and need to understand this better to be able to say how old is too old to be a dad. I just wanted to finish with one last quote. It's an interview with Rod Stewart. And they said to him, look, you've got 2 young boys. Do you think you're a better father in your 70s than you were in your 30s? And his reply, oh yeah, I should hope so. My goodness, if I haven't learned the trade now. Children have always been important to me, very important. But I had Kimberly and Sean in the late 70s when I was in debt. I had to go out, I had to work a lot. So I missed a great deal of them growing up. We've sat down recently, we talked about it. I said, I wasn't going out and partying and drinking. I was working my arse off to try and get out of debt. Sorry about the language. He said, I've built a lovely AstroTurf pitch for my 2 youngest boys. One's 12, the other's 7. We go out there every evening. I try and teach them a few things. That's the most wonderful thing ever, just playing football at my age with my kids. And I think that's a lovely thing. And I think there probably isn't too old to be a dad.
Our next speaker now is Dr. Anna Smajdor, and Anna is an Associate Professor of Practical Philosophy at the University of Oslo, and she is Principal Investigator at on the multidisciplinary research project, Epigenetics and Bioethics of Human Embryonic Development.
Thank you very much for inviting me to this event. It's been a fascination of mine for many years now, the ways in which people think about age and reproduction. And what I want to do in my talk is put forward an argument, a very straightforward argument in some respects, that attempts to demonstrate why young people should freeze their eggs and sperm. And in putting this forward, I want to expose some of the complexities that I think often get hidden when people are thinking about age and reproduction. So to start off with, here's my argument. If aging gametes harm offspring, and we should always avoid harm to offspring, and people are often not ready to become parents at the optimal time for their sperm or egg health, then it seems to follow that we should urge young people to freeze their sperm and eggs so that they'll have healthy gametes by the time they are ready to reproduce. So as I said, this is a relatively straightforward argument. I'm a philosopher, and it has some reasons and a conclusion, and it ticks those boxes. But you will notice there's a very big if at the start of it. So what I want to do is work through these premises of the argument and see what follows from them, whether they're true, and if so, whether we have to accept this conclusion. So let's think first about whether aging gametes are harmful to offspring. And I think this is a really complicated question. So if we start by thinking about aged eggs, as the scientists and medics have shown, there's an elevated risk of chromosomal abnormalities. We've known this for many years, and women come under a lot of pressure about the timing of their reproductive choices, because we know so well that an older mother is at greater risk of having a child with Down syndrome or other chromosomal abnormalities. But one thing that seems to follow from this is that actually it's the age of the egg rather than the woman herself that's responsible for these adverse health outcomes for her offspring. So that poses us a question. If we could take the eggs out of the woman while she's still young, then we would avoid some of these risks associated with aged parents. In effect, you would be an aged parent still, but your eggs would be lovely and young. So let's think about sperm. And I'm really glad that one of our speakers focused on men because, as I've said, it's very easy to get fixated on women as being the reproducers of our societies. So far, we still need men for reproduction as well. And it's becoming increasingly evident that, as we saw, aged men with aged sperm also transmit health risks to their offspring. So, does it harm a child to be conceived with aged gametes? This is a really difficult philosophical question because we're not offering a child the option of being born with young gametes or with old gametes. A child can only be born with the gametes that go together to make it up. So this makes it a very hard question to answer. The child that's born to the man of 89 may have health problems as a result of being conceived with aged sperm, but there were no other life options available to that child. If his father had had a child earlier, it would have been a different child. Nevertheless, people tend to have very powerful intuitions that say we shouldn't have children in circumstances where we know that they're going to suffer terrible harm. And one of the important questions here to ask, I think, is it terribly harmful to be born to an aged parent? Is it so harmful that we should really be intervening and saying to people, you're too old to be a parent, your child's going to be horrifically damaged by your agedness? If so, then maybe it would make sense to encourage people to freeze their gametes. But my honest answer here is, I don't know. But let's just give this, for the sake of the argument, let's say, yeah, aging gametes harm offspring. We have reasons to worry about that. So then let's think about the question of whether we should always avoid harm to offspring. And for most people, this seems so obvious that I might appear to be an evil person for even questioning it. But I think it's really important to question it. Why? Because a whole lot of underlying assumptions lie hidden in this kind of cloak of avoiding harm to offspring. So if we accept, for the sake of argument, that aged gametes cause harm to offspring, then we can ask ourselves, okay, is this something we have to act on? And my question here is, well, why would we be agonising about aged parents. There are many, many things that cause harm to offspring in our societies, and I'm not sure that aged parents or aged gametes are really the worst things that can happen to a child. And I want to point out some very contentious facts here. Low socioeconomic status is recognisably associated with poor health outcomes and lower life expectancy, irrespective of the age of the parent. So if we should always avoid harm to offspring, we should be stopping some people from reproducing, maybe. I think most people would really flinch at that idea, in a way that they might not flinch at the idea of trying to stop old people from reproducing. And my question is, why? Is there a good justification for that? I'm not sure. My other point here is, babies conceived via IVF are at elevated risk of a whole lot of health problems. And yet we offer IVF and we celebrate when someone has an IVF baby, knowing that the risks to that child are in excess of what a naturally conceived child would be exposed to. So if we need to worry about harm to offspring, there might be more important things on the table than parental or gamete age. So my third point is, well, you know, what's going on with young people? Can't they just get on with it? Recently, the Norwegian Prime Minister, where I live, issued an urgent decree to Norwegians to make more babies. Norway needs your babies. Have them now, you know how it's done, she said. But apparently people are not doing it. Birth rates are catastrophically low, according to various media sources and demographics. And even though, as I say, Scandinavian countries offer the most amazing packages for parents, birth rates are plummeting there too. So my point here is, the values of modern democracies don't seem to be compatible with young parenthood. And given that, maybe we should be urging young people to freeze their gametes so that they avoid these risks to their children. And that might be one way of resolving this problem. But as I said, I want to highlight some other ways of looking at these questions. So rather than conclude that young people should freeze their gametes, maybe we should think more carefully about how we think about harm in reproductive choice and whether avoidance of harm is really what is motivating us. And last but not least, do young people really have a responsibility to populate the state? Maybe we should be thinking otherwise about that. So my aim is to put these things out there, I guess, and maybe stimulate a different way of thinking about these questions. And that's the end of my talk for now.
And now we have our final speaker, Professor Glenn Cohen. And Glenn is Professor of Law and Director of the Petrie Flom, apologies if I've mispronounced that, Centre for Health Law Policy, Biotechnology and Bioethics at Harvard Law School. And he's also a fellow at the Hastings Centre. So we're really pleased that he's joining us from the US this evening.
I'll start by just offering some disclosures. There's nothing that I am disclosing that I think is problematic, but better to over disclose than under disclose. Okay, the question for today is, how old is too old to be a parent? And the answer I'm going to give you is there's no such age that's too old, at least as far as the state is concerned. So I get to be the brash American, although I was born in Canada, and I get to also turn all of the good things Dr. Smajdor put as question marks into exclamation points as I make these points. Let's start with some starting points. First starting point, important common ground, is the following assumption. People should be free to do what they want with their bodies and their reproduction, unless the state has a very good reason to restrict them from doing so. And that's an idea that has super deep roots all the way back to John Locke's conception of self-ownership, and much further back, in fact. And I also want to say here that the involvement of a doctor and the need to rely on the medical profession doesn't change this premise any more than it does the fact that women need to rely on physicians when they're seeking an abortion. The right is facilitated by a medical professional, but it's the individual's right. I also want to start from a presumption of justice in its most simple form that I'll associate with Aristotle, the idea that we have an obligation to treat like cases alike. What that means is a question of reproductive equality. We need to avoid disability discrimination. And just because someone needs medical assistance because they have a certain thing about them that prevents them from carrying out what those can do coitally through intercourse, they need to use reproductive technology, does not mean they should have any fewer rights. And moreover, and this is one of the exclamation points from Dr. Smajdor's test, I think that anytime you want to impose an age-based restriction, you have to ask yourself, would I be willing to impose the same restriction for the same risk of harm to every other population? Be that the poor, the single, same sex, somebody who just has a genetic disorder. And unless you're willing to do so, unless you can pass that litmus test, you're engaged in a form of age discrimination because there's no morally relevant difference. Okay, now on to arguments. I want to suggest when people want to restrict people's ability to reproduce, they are calling on one of a series of argument types, but they very rarely admit that this is what they are doing. So we should be very clear what kinds of arguments that could be marshaled are. First one is paternalism, harm to self. We should prohibit older people from becoming parents because we need to protect those people from seeking services. We know better than they do what's going to harm their self-interest. I got to say, it doesn't hold a lot of water to me. Maybe this is an argument for robust informed consent requirements. Maybe it's an argument for speed bumps to access services. But I really don't think the UK government knows better than somebody who's 70 years old whether having a child or not will make their life go better or worse. And again, as a matter of equality, if you are convinced that the UK government knows better in this instance, then you're probably also convinced they know better for single individuals, poor individuals, people with genetic disorders, and people who are same sex. And they should be able to put the same restrictions in place as a matter of paternalism. Very few of these arguments are founded on paternalism, though. Instead, the strongest argument that's often made, but one that I think is not actually understood as such, is what I call the best interests of the resulting child argument, or BIRC for short. The idea that we are going to harm children if we allow these acts of reproduction to go forward. Now, this is attractive because it draws on John Stuart Mill's harm principle, and it applies it to a particularly vulnerable group, children who result from reproduction. Nobody wants to hurt a child. And from a political theory perspective, it's a very attractive way to try to justify state interference in reproductive decision-making because people are harming a vulnerable group, children. And these harm principle arguments are typically accepted even by libertarians. It's also quite attractive because it trades on a kind of echo of something we say in family law all the time. When we think about adoption, when we think about removing children, we talk about the best interests of existing children. And it sounds like it's the same thing, but it's not. It simply doesn't compute. You're talking in this instance about protecting, quote unquote, protecting children out of existence at all. And this point was at the heart of the British philosopher Derek Parfit's non-identity problem from many years ago. The punchline of the problem is that we cannot be said to harm a child by creating them so long as we give them a life worth living. That is, a life that is not so full of pain and suffering, so devoid of anything good, that the individual would have preferred never to have come into existence. And even if lives not worth living exist, and I have some skepticism about what they might look like, it's extremely hard with all the data that's being presented. Take the most favorable study for restricting aged reproduction here. It's extremely difficult to say this is a life not worth living we're going to give to these children. It's not as though there are babies out there that the stork is delivering, and the question is, do they deliver it to the aged parent or to the younger parent? No, if we prevent this act of reproduction, there is no baby to bring to someone else. The baby doesn't come into existence. Therefore, this kind of argument is just logically problematic, and it trades on a mistake in logic and thinking we can talk about harm and benefit. Okay, well, if not that, then what? A third possibility is that the harm is not to the child, but to society, to the taxpayers, to the NHS who may have to pay for the healthcare costs, or to compensate for children whose poor performance in life fails to allow our society to flourish. Now, there's a huge amount of empirical assumptions going on there. So much for the world of art, politics, activism are based on the lives of people who had poor rearing conditions or had a single parent raise them. So I don't know why we're jumping to this conclusion. But even if you believe that the empirical evidence said this, which I don't, to be clear, there's many, many problems with making this kind of argument. Let me offer you 6 in a list. First, the harms involved to third parties to society are extremely attenuated if they even exist. Second, there's a significant under-inclusivity problem here as to what forms of reproduction are regulated, for the principle of equality says we should feel free to interfere with any reproductive act that purports to impose the same number of externalities. Again, the single, the poor, those with genetic conditions, all of them impose externalities. We don't police the activities of people engaging in coital reproduction on a Saturday night. Third, the approach may justify government-enforced enhancement to reduce externalities. Fourth, it doesn't grapple enough with the idea that children who are born produce positive externalities to a society. Fifth, if externalities are the problem, it would be better to force individuals to internalize those externalities rather than say no reproduction at all. And sixth, I want to suggest that the basic element of this argument is the same argument behind eugenics, that we have an interest in creating a society that looks a certain way, and therefore we have a right to interfere with people's reproductive choices on that basis. The means may be different, but the goal is the same. And if you have a problem with old style eugenics for the purposes of what it was trying to achieve, maybe you should take a second look with this kind of argument. Okay. Well, if I've convinced you that none of those will work, what are left? And we can talk about this during the Q&A. There's a family of arguments that are sometimes called wronging without harming, that we concede no child is harmed by being brought into existence with an older parent. In fact, they're benefited overall, but nonetheless, we think the act of reproduction is wrongful. First off, I'm going to say, and we can talk about this, I think very few politicians or public policy people actually subscribe to this kind of argument. But if they do, there may be some problematic implications, including the idea that every act of reproduction is actually prima facie wrongful. And anytime we reproduce, we're doing something wrong, which seems to be a somewhat untoward implication. Maybe you think this is a question of virtue ethics, that a virtuous parent would never be selfish and reproduce when they are 95 or whatever it is. And that's the reason why society should intervene. Gotta say again, I'm not a huge fan of legal moralism and thinking that it's the part of the UK government to impose conceptions of what a virtuous parent is and what virtue looks like. But even if you think so, I think it's problematic to articulate why it is so unvirtuous to reproduce at this advanced age if we're not talking about harm. Finally, there's a group of philosophical ideas called non-person affecting principles, that the idea that the world is better off impersonally, even though no one is harmed. Quite hard to wrap your head around. But what I want to suggest to you here is, as to advanced maternal and paternal age, we're talking about what's called a different numbers case, not a same numbers case. We're talking about changing the number of children that come into existence, not merely substituting one for the other. And when you are in a different numbers case, much harder to argue that there are non-person affecting principles that support this outcome. Okay, a ton more I can say. Hopefully I've stirred you up, which was my goal, and I'm looking forward to the Q&A.
So you kept perfectly to time, and that's great. We've got lots of questions now coming in the Q&A. I think we've got going to have some really juicy discussions. So I'd like to welcome Sarah Stock, Sarah Martins de Silva, Anna back to join us. That's great. And I think the first question is I'm going to take is from Nick Macklon, and I think that's a question for Dr. Sarah Stock in the first instance. Has there been any change in the age-related risk of maternal morbidity over the last 30 years? In other words, are older mothers healthier now than older mothers were back then?
Thank you. I think it's a really difficult question to answer in terms of we've got better at dealing with some maternal morbidities across all age groups. So if we think of something like preeclampsia that we know age is a risk factor for, we're actually much better at preventing complications from preeclampsia and eclampsia. And so certainly maternal mortality has reduced in this area. On the other hand, we have other conditions, problems with placentation, which can cause bleeding and catastrophic hemorrhage around the time of birth or after birth. And rates of those are going up. And they're really heavily associated with caesarean section modes of birth. And of course, those rates are going up again across the board, but if you're older, you're more likely to have had previous caesarean sections, you're more likely to have had complicated pregnancies and complicated births, which can predispose to this. So I think it's really hard to sort of say women are healthier now, older women are healthier now, that affects pregnancy complications per se. I think overall we do know we've got better at predicting pregnancy complications and managing some of these, and we can target those efforts at older women because we recognise it as a risk factor.
Thank you, Sarah. And I think I'll take another question, and then because this one is for Sarah Martins de Silva. Would you like to comment on the effects of paternal age on miscarriage? And this is from Professor Sheena Lewis.
Oh gosh, Sheena, well, yes. Well, there's clearly going to be some sort of discussion there in terms of the acquisition of sperm DNA damage as men get older. Clearly, in terms of creating a pregnancy, you have an egg and a sperm, and if you're taking damaged DNA into that egg, what the egg's corrective capability might be, creating a pregnancy with perhaps genetic faults, which we know is a huge underlying cause of miscarriage. I think something that we haven't really looked at and perhaps would be really interesting to look at is we know that the sperm contributes to the trophectoderm, which is the outer covering, as it were, of the blastocyst of the embryo, and whether there is actually an implantation effect that we haven't really explored and don't really know or understand. I don't know is the honest answer. I think sperm DNA damage would be the easy answer, but I think that there may be more to it than just that we don't know yet.
Great, thanks for that, Sarah. As always, we need more research. The next question I'm going to take is from Dr. Jane Stewart, and that is for Anna, although I think others may want to chip in on this. So she says, perhaps, in fact, our young people are seeing the effect of overpopulation and taking a positive decision to avoid this, hence the population decline. In that case, they may not want to store, even if it were made super easy. It is perhaps the older people who see the loss of population support in old age who want them to procreate more, thinking about our pensions. After all, family sizes have been reducing over time too. So Anna, if you want to have the first crack at that one, please.
Yes, well, I think it's a great question. And I blame you, Sarah Norcross, for only giving me 8 minutes, which I think I overstepped as it was slightly. Of course, there are, it's a really complex picture. And one of the things that I think is really important to consider from an ethical perspective is why is there so much pressure on people to reproduce at certain times in certain ways with certain people, when we know that there are other moral concerns for the environment and in terms of overpopulation. It's as I say, it's a really complex demographic question about overpopulation, and I'm not an expert in that. But I certainly think it's worth asking why we assume that that young people should be getting on with it. My feeling is people are under enough pressure already, and people like the Norwegian Prime Minister, apologies to anyone who who thought that that was a fantastic thing she was doing. I think it's intrusive. I think it's ugly to require that of people as though they're breeding cattle for the sort of state farm, so to speak. So I agree. We should think about overpopulation, demographics, the environment among these other questions as well.
Glenn, would you like to come in on this one?
Yeah, it's a very interesting question. So one of the interesting questions I ask people is, what is the optimal number of people to exist in the world at any one time? And how do we imagine, so this is again rooted in philosophy and Parfit, if we imagine that we could double our population, but everybody's life was half as good or a third as good, would that be a better world to live in or not? Does every new life that we add make our world better? Or should we look at the average welfare of the child born and see whether the average goes up and down? One more non-philosophical but pragmatic thing that's an interesting question when it comes to fertility preservation, which is the way in which fertility preservation would have a gender equalizing effect versus a gender regressive when it comes to equality effect in the following way. Many countries and many employers face an obligation to make sure that women who do take off time now for pregnancy, for example, have a way back in and are not adversely impacted. In a world where everybody could freeze their eggs and get pregnant later, which is not true, by the way, and that many of those pregnancies will not take, but where that is the messaging, do you encounter a world where those companies say, well, I'm not discriminating against women. I'm only discriminating against the subset of women who decided not to freeze their eggs and decided to have children now at this stage of their career rather than later. So that's a social fact, and whether our anti-discrimination law is actually up to par in that particular situation, I think is an interesting and difficult question.
I think actually one of the comments, so it's a comment really in the Q&A, is from Colin Duncan, who says the elephant in the room with regards to equality is that a 60-year-old man can reproduce without ART, unlike a 60-year-old woman. And I think that's sort of one of those things is, you know, should we be seeking to level the playing field here? So I'm going to do either of the other two Sarahs want to come in on this one. I'm guessing that's a no. So
Sarah M is waving her hand.
Oh, sorry.
Gallery view on.
Yep, Sarah Martins de Silva.
So I wanted just to pitch in quite a controversial thought here, right? I think the youth of today may well be much more in tune with the environment and looking out for, you know, and not overburdening the world and all the rest of it. But actually, you know, on an individual basis, on the couples that I see in front of me in an infertility clinic, looking for treatment where you're saying to them your age is an issue, they haven't deliberately postponed having kids because of their, you know, concern for, you know, global warming or the ozone or whatever. I think we're all on some level far too selfish. We want to reproduce. A lot of people want to reproduce. And I think you have to look at the beginning and the middle and the end of somebody's reproductive life. And then we have to target kids in school and say to them, you have a biological clock. Girls, you have a biological clock. Boys, girls have a biological clock. Everybody needs to know that because it's so focused around protection and preventing unwanted pregnancies and preventing sexually transmitted infections, which is hugely important. But it's also, there's got to be a balance to that argument, which is if you want to have children, it's easier to reproduce naturally than requiring IVF or donor eggs or donor sperm or freezing stuff or whatever. And I think that then plays out. And I get what you're saying, Anna, about it. You know, I think, you know, you've got to count. It's not about making people reproduce that don't want to, but it's about telling people and empowering them to make a choice. If they want, most people, if they want to have a family, they know they want to have a family. They just may not know when and how and who with. But it's empowering them to know that, you know, you might need to make a decision at some point sooner than your 45th birthday, for example. You know, it's just about getting that message and that education out so people can make informed choices. Because I think the studies that are out there show that women who are involuntarily childless are not involuntarily childless because they're worried about the planet, not the current 40-plus-year-olds.
And I'm going to sort of put in another question here, which is related to this really, to some of the points that you just made, Sarah Martins de Silva, and this is from Lucy Richardson. There's recently been a drive to inform young people how fertility declines, with a particular emphasis on females. Are we scaremongering and frightening future generations out of important opportunities, including education and careers? So I don't know who wants to go first on that one. I can see Anna looks like she's drawing breath, so I'll go to you first, Anna.
I'm sorry, I lost a little bit of what you were saying. Can you repeat the question?
Yeah, sure. There's recently been a drive to inform young people about the decline in their fertility, with a particular emphasis on targeting women. Are we scaremongering and frightening future generations out of important opportunities, including education and careers? And I certainly remember reading a book quite a long time ago now where it said, you know, the worst thing for women's fertility was allowing them to go to university. I think it was, I hope it was said in jest, but we sort of get where they're coming from.
Yeah, well, I think it's really worth noting that it's very common to hear this argument that women are ignorant, that they're making poorly informed choices. But one of the things that seems problematic with that idea is that it's the most highly educated women who have the fewest children, basically, or who have none at all, or who have them later in life. So I think there's a kind of clash that I was trying to get at in my talk between the value of education and the value of parenthood while you're still young and beautiful. I don't think those things can really be made to marry up, if you'll pardon the pun. And so maybe something has to give. I think I would disagree to some extent about the idea that it's scaremongering. I think one has to be really careful about tone in sort of public education campaigns. I've seen some very bad examples of it. For example, the Italian one, when there's a poster of a beautiful woman and an hourglass saying, beauty doesn't last forever, and no, fertility doesn't last forever, beauty does, something like that. Anyway, it was a bit crass. I think it's a good idea for people to understand about their fertility and to be educated, but our societies have so much inclination to pressurize people that it's very hard for them to provide information in a way that is not overly directive or normative. So sorry, that was rather an involved answer.
Glenn, would you like to come in on this one as well?
I think, again, the question you want to ask yourself is, what is it we're trying to do and how are we achieving it? So what is it we're trying to do, right? Is it that, as I think one of the other speakers put it, the state farm wants to produce more cattle so that the society does not collapse, right? That's one vision of what we're doing. Another is we want to empower people to make good choices and make choices that are right for them. Two very different visions, and the kind of information campaigns you'd want to run would be very different depending on what it was. And I'll just say that we should be aware of intersectionality here. So I'm not as familiar in the UK, but in the US, for example, many women who are infertile, who are Black essentially, are often counseled away from infertility or not approached for infertility due to pre-existing biases about female fertility by certain ethnic communities, and also due to availability and access, right? So it may not be that we need to generally do less scaremongering or more scaremongering, but we need to think about equalizing access to these resources, even if they are formally available to everybody.
Do any of the rest of the panelists want to come in on this one? No? Well, I've got another question. We're going down the sort of legal philosophical route a bit. Glenn, would you introduce a statutory upper age limit on parenthood? I think I'm guessing the answer to this, including via adoption. And would it be incompatible with Article 8 of the ECHR?
Yeah, I'll confess to say that I'm not a European Court of Human Rights expert, but that's okay. I can vamp a little bit on this one, just say the following. So one thing I do know is that across Europe, we have wildly different rules regarding reproductive technology access, including by sex, including like I think of Italy's law 40, I think is what it was called back in the day, and even the HFEA Act before it was amended had a bunch of this stuff to it. My understanding is that the ECHR has not yet suggested that any of those go beyond kind of, you know, the margin of appreciation, the like, but this might be a future space of contestation. In the US, where I'm from, one of the most fundamental questions that have never been answered is whether, as a constitutional matter, you have a right to use reproductive technologies at all. So could the government ban ART completely, or would that violate the Constitution? And again, as you know, we're in the midst of a confirmation fight in the United States, which is about contested values and about visions of the country. And unfortunately, our legal system is much more beset by a certain, shall we say, partisanship than I think many other countries. So, but on the ECHR, I'll say one more thing, which is to say, above and beyond all this, there's also the fact that there's a huge amount of medical travel, medical tourism for reproductive technologies across Europe. And partially that is a result of decisions to be restrictive in some places, but produces all sorts of odd situations where you get on the channel and suddenly you can get what you couldn't have gotten somewhere else. But guess what? You have to pay for it. And therefore, only those who can afford to pay for it, pay for it.
Yep. I think there's some agreement there. Thank you for dealing with European law. That's very impressive. So, and that was from Blair Sowery, who's just started writing for us at BioNews, actually, and I should have given her a shout out. Should have given him rather a shout out. The next question is from Liam Davis, and that is for Glenn and for Anna. If there isn't a theoretical age limit after which people cannot become parents, isn't this inevitably going to impact or police non-fertile parents more, especially queer families, as those that can have a child naturally would escape the state's view and can reproduce anyway? So, Glenn, do you want to go first on that one?
Sure, 100% completely agree. And this is one of the things that worries me about this, because it turns out we are selective in who we use the heavy machinery of the state against, and it's very easy. Now, there was another comment here, which I think was interesting in the comment chain that is related to this, which regards this question of the natural versus assisted reproductive technology. And aren't I drawing a false comparison between the two? And I think the answer is no. And let me give you my best pitch as to say why no. I view many people who cannot reproduce as victims of medical or biological realities for which they are faultless. They've not found a romantic partner, they have infertility. And just as if you told me that there was a sexually transmitted diseases, as there are some, that would have the result of taking away a woman's ability to reproduce naturally, and you asked me, does the state have a role in preventing that, or should the state pay for it? To me, it seems the answer is yes. So I don't see the difference between reproductive technologies and, for example, providing an artificial limb or a wheelchair to somebody who doesn't have the opportunity. I think this is called on for a question of making people whole and giving everybody access to life plans that other people do. Now, maybe there are some stopping limits, but I'm skeptical that there's this strong bisection between the natural, what heterosexuals can do on Saturday night, and what everybody else who is infertile or not heterosexual has to deal with in terms of going before a doctor and saying to you, I am at your mercy, enable me to do what other people in the society think nothing of.
Yeah, I'll just point out now that Glenn, the way we are with COVID at the moment means not that all adults can get it together in the UK on a Saturday night anymore. It's quite complicated to follow the rules as to who's allowed to do what with whom, when and where. But Anna.
Yeah, I think I disagree with you on this one, Glenn, at least in part. It seems to me that it's definitely true that one of the most profoundly important moral concerns that we should have is for bodily integrity, and that any state intervention on our bodies is something that is terrible to contemplate. And for me, that means there is absolutely a distinction between people who can reproduce naturally and people who have their reproductive options constrained by the state. So in one case, to constrain the reproductive outcome. It's going to involve the state coming into the bedroom or your body and doing stuff to you. In the other case, it involves the state saying, sorry, no, we're not going to help you. I think there's a very important moral distinction there. I'm not saying that justifies refusing some people treatment, but just that there is a moral difference. And I do think that there's a big difficulty that maybe we see more in the UK with its publicly funded health system, which doesn't do very well when it comes to reproductive technologies, of course. But in theory, the provision of healthcare from that health system has to be in response to a medical need. And that's the big sticking point for this. Because as you say, you know, healthcare is there to make people whole. Yes, it is. But a health system also needs to define need in some way. And the way that reproductive need is defined in the UK, I think is very, very poor and unconvincing. But the way that you describe it, I think, is also problematic for a health service that has to say, hang on, can I pay for all this? Are there higher priorities with health funds? So I think there are really important questions there, and maybe there are some, I don't know if it's cultural differences or health system differences at any rate.
I don't know whether either of the Sarahs want to come in on that one. Yes, Sarah Martins de Silva.
So it's a really interesting one, isn't it? When you talk about fertility services, and clearly when you have a NHS funded system and you have a finite amount of resource, I would point out that in Scotland, we are incredibly lucky. We are very generously funded as per NICE guidelines. You know, if you're under the age of 40, most couples will get IVF. Same-sex couples should have access to donor insemination, egg donors for same-sex male couples. You know, I think, you know, what you're saying, Anna, if I've misunderstood you, is that you're not quite perceiving infertility as a health need or fertility as a health need, which I have major a disagreement with. I think it is a very valid thing, as much, you know, and I just, you know, I think the reality then is the kind of play on from that, if you get a couple pregnant, is that there is then an expectation within the UK that that pregnancy will be looked after within the NHS, that a high-risk preterm baby will be born and looked after in an NHS-funded neonatal intensive care unit or special care baby unit, that the woman with the very difficult placentation that needs intervention radiology and all the rest of it for safe delivery will get all of that with absolutely no apparent cost at service. So I think, you know, when we apply rationing, which we do in every sector of healthcare, that it needs to be robustly done and fairly done. And I think we do that reasonably well in Scotland particularly. But also then, you know, the reason that we worry about older parents goes back to what Sarah was saying about them being higher risk pregnancies, about higher risk births, about higher risk for preterm delivery or other healthcare problems in the children, which the NHS also needs to carry the cost of. So I think, you know, I think it's really, really difficult. And I think it goes back to what Colin Duncan also said, which is if somebody decides to reproduce or a couple decide to reproduce on their own terms without involving clinics and clinicians, it's quite different. When a couple are sat in front of me, I have to complete forms that say, you know, from the welfare of the child point of view, I perceive no risk to this child. You know, it's very judgmental, and I can't say that I can really think of people that I've stopped going ahead with treatment, you know, but there are criteria that they need to meet, and there are reasons for that, and the BMI and the non-smoking and all these things are about having a healthy mom and a healthy baby at the end of the day. And so that's how we apply rationing, is by making people meet the criteria. But, you know, there is such a difference between a couple sat in front of you who, you know, have a fertility need, and I've got to deliver that or make a judgment about whether that is something that the NHS can do.
And I think Sarah Stock wants to come in.
Yeah, I think when we're talking about rationing, it's so difficult, but to come back to, doing this on age as a related risk for maternity complications for the mother or baby, we're really we're really oversimplifying, aren't we, going to a fallacy? And I think as Glenn and Anna spoke very eloquently about, we don't apply these risks to other groups. We don't do it based on ethnicity or race, which there are very good evidence now of high risk of maternal mortality or perinatal mortality associated with race in the UK. We don't do it on other risk factors. We would not ration just on a risk-based system in other for other risk factors, and so it is very difficult to do that just on age. I think now I appreciate your argument, Sarah, that we have to do it on something when you've got couples sitting in front of you. But I think that we've got to put risk in context, and if we're just using age as a rationing tool purely because of maternal risk, then that is very problematic.
So we're running out of time, but I'm going to take one final question. I want you all to give a very, very quick answer to this. So forget about nice guidelines and those sorts of things and those sort of criteria for treatment, and that we don't have an upper age limit, an official upper age limit. But so this question is an anonymous attendee. Should all UK fertility clinics remove any upper age limits they have for women if they're using donor eggs? So it can be a simple yes or no. So we'll go to Glenn first. You can tell us what to do in the UK.
Yes.
Anna?
Yes.
And Sarah Martins de Silva?
I don't know.
You're allowed not to know.
No. Although I'd like to say yes, because actually I don't do obstetrics, so yes.
And Sarah Stock.
And I do obstetrics, and I'm going to say yes.